Hey y'all, it's Charda from Melanin Milk SD. I'm a mom, a certified doula, lactation consultant, childbirth educator. So today I'd like to offer you a quick breastfeeding lesson to explain some of the possible reasons for your breastfeeding pain or discomfort and a couple ways on how to fix it, because sore nipples are not fun. They're not. Breastfeeding should be pain-free. Now, not all nursing people experience nipple soreness, but it is very common for both new and experienced lactating people to experience some level of discomfort at the beginning of their breastfeeding journey. The typical discomfort that's associated with the first latching usually lasts for about 30 seconds into the feed and goes away after that. A lot of my clients describe it as a mild sensation. You must remember that pain is subjective, and so some people might describe this as a little bit more severe, but this shouldn't continue throughout the feed, and it definitely shouldn't be after the feed or between the feeds. So this heightened level of sensitivity usually lasts for about the first 2 weeks into the breastfeeding relationship, and it should go away after your nipples and breasts just become more accustomed to having that constant stimulation, something that previously your chest wasn't used to having that much stimulation before. And so right now it's just learning to get used to different sensations and different feelings from the baby latching, from you pumping, from you hand expressing, from being engorged, all those different feelings that come with the beginning of the breastfeeding journey. It just takes a little time for you to get used to it. And there should never be any damage to your nipples or your skin on your breast. And when I say damage, I mean cracks, bleeding, there's milk blisters and milk blebs. That would be like a small white bump. It's usually at the tip of the nipple. It's hard like a pimple. It's like ready to be popped. And that's what it looks like. It's usually dried up milk that's collected in your milk ducts, and then it's come to the surface, so it's just sitting there. Your nipple should be the same shape coming out as it was when it went in. At the beginning, it might be a little compressed, but it shouldn't be flattened. It shouldn't be creased, pinched. It shouldn't look like a fresh tube of lipstick. This could further indicate that there's something anatomical going on, and so you definitely want to go ahead and get your baby an oral assessment and get an assessment of your breast and chest as well. There are usually some tricks that I can provide to my clients or potential clients that contact me with these type of issues, and I give them something to get through the next couple of days until they're able to get in and see an IBCLC. I also hold virtual support groups as well as in-person support groups if you're in San Diego, so that's another way to get some free help if you need a little bit of guidance on how to treat some of these common concerns. Hopping into one of my support groups is a great way to get some free advice. If you experience intense excruciating pain that continues throughout the entire feed, pain between feedings, and like we mentioned earlier, any type of skin damage, any type of nipple damage that you see or that you feel, you need to contact a lactation professional immediately and find a good one, because we're not all created equal, honey. We're just not. Don't let anybody tell you that everything looks fine if you have skin damage or nipple damage. You don't have to suck it up. You don't have to deal with the pain. You don't have to suffer. It doesn't have to be this way. Seek help. I'm here to help. This can be a highly emotional process of learning to latch your baby, even if it's your 5th baby. Every baby's different, right? And so we're learning together with our baby, and we just have to have some time and some patience to just sit down and take some breaths and figure it out together. Number 1, poor positioning, shallow latch, poor latch. Shallow latch and poor positioning can lead to nipple damage. It can lead to breast damage, skin damage. Bring the baby to you. Don't come to the baby. Don't bring yourself to the baby. Don't hunch over. A lot of us hunch. And when we're trying to get the baby to latch, we do this. We want the baby to be at nipple height level with your breast, or we want to make sure our breastfeeding pillow or the pillows that we use from the sofa or the bed are nice and firm. So that's how we avoid some of that poor positioning and the nipple damage that we get from poor positioning and poor latch. And now you want to get ready to latch your baby, okay? You might want to first give them a finger to suck on, to get them nice and organized and to orient themselves to the breast and to the feeding experience a little bit better. Rub your nipple from the nose down to the chin. down to the chin, and that helps the baby to open wide. If the baby goes on with a little tiny latch and their lips are like this and they're trying to pinch, then it will be super pinchy, super bitey, clampy, and it will be painful. So that's why we don't want to do a shallow latch. We want to make sure the baby opens really wide so they can get on that breast and get a whole bunch of breast, areola, and nipple in the mouth, not just the nipple, not just the tip of the nipple, because that's what's giving you the pain. If you watch my previous video on the 5 S's, you will know how to soothe your baby quickly and efficiently to calm them down, to get them onto the breast, to be able to latch and be organized and be calm, cool, and collected, both of you. So here's how we do the nose to chin. You have the nipple run from their nose to their chin, okay? And this will elicit a nice open wide. I'm going to bring my baby in. I'm gonna hug them in closely, bring them in, okay? If you were eating yourself, right? You wouldn't stuff that food in your mouth. You would bring yourself to your plate, right? And so we wanna just remember all those things when we're breastfeeding, because we're feeding a baby, they're eating, this is their food, and we wanna treat it as such. Just don't forget to try different positions. If the football hold that they showed you in the hospital is just not working out, it's not working out anymore. You didn't like it anyway. Move on, try a different position. You might want to try cradle hold, okay? You might want to try cross cradle hold. You might want to do a laid back hold. And you can do laid back in a cradle as well. And on Instagram, I'm at Melanin Milk SD, TikTok at Melanin Milk SD. And there you can check out some of those breastfeeding holds that I was just talking about, and you can see them a little bit more in depth. So when you start experimenting with those holds, if you can get into a deep laid back hold, then that will help you to get a deeper latch. That'll help baby to get a deeper latch, which will prevent shallow latching, poor positioning, and all these issues that we've been talking about that lead to nipple or skin damage. Recap on number 1, bring baby to you, not you to the baby. Get a deep latch with laid back hold, and make sure that your baby has a nice bit of areola and nipple and breast all sandwiched in their mouth, not just the tip of the nipple. Try different positions. That is not meant to be sexual, I promise. Number 2, engorgement is super common in the early weeks postpartum. We're talking like first 2 to 3, maybe even up to 5. I've seen people dealing with engorgement. Normal physiological engorgement is very common in the first 3 to 5 days postpartum. If you had a vaginal birth, and up to 6 or 7 postpartum with engorgement. If you had an abdominal birth, which is also known as a belly birth or a cesarean/C-section. With a belly birth, sometimes things can be a little delayed, and so that's another good reason to work with the lactation consultant on these issues if you're experiencing them in your early days or weeks postpartum. Engorgement in those first days is really just your milk increasing in volume, and so when it increases in volume, it goes from little drops to big amount. Your milk ducts begin to change, begin to swell. Engorgement from not frequently emptying the breast effectively and efficiently. Sometimes you may wake up with engorgement that might be mild. Put the baby on or pump or hand express to get that initial milk out. You don't want to do an electric pump because that might confuse your body and trick your body into producing more milk than is actually needed. If you wake up with rock solid boobs in the middle of the night, a little bit of hand expression or massage might be all that you need to kind of get that out. If you are engorged and having some trouble latching your baby on, that would be another reason to do some hand expression or reverse pressure softening in order to get some of that milk down or some of that inflammation down so that your baby has something to ridge onto. Because when the breast becomes so engorged and so hard, it goes a little bit more like this, where the skin is taut and tight, and it's hard for the baby to latch on. And sometimes this nipple even goes in like that, and we deal with a flatter breast, and so we want to to put some pressure there to let that nipple pop out a little bit and then give our baby something to grab onto. So what can you do for engorgement? You can loosen the milk with warmth. So you can use heating devices. They have them on the market. You can use those massagers and things that you see, or warming devices, or breast warmers. I did post some by Freedom Mom on my Instagram, and I really love those. They're reusable. You can throw them in some water and they heat up, and you can reuse them, which is what I really love. I like to just go old school and use rice in a sock, tie that sock closed. Sometimes I'll put a few essential oils in it, throw it in the microwave. Once it's warm, I'll put it on. If we're experiencing pain between the feeds or after the feeds with engorgement, then we'll want to use cold for the pain to reduce the swelling, reduce the inflammation. And that cold could be something as simple and cheap as a bag of frozen peas. Love that. I love frozen peas for it. A lot of lactation consultants love it. I personally like it because I like the way the little nodules of the peas, they really get into all the milk ducts because it's pressing on, and it's little pockets of cold. And so those little pockets of cold are just, penetrating all around the breast, really able to get into those ducts and remove some of the swelling. You can really use whatever you'd like that's in your freezer, just anything that's cold, ice packs, a bag of ice with a towel over it, old school. I'm old fashioned and traditional. That's what I would do when I'm at somebody's house and a lactation consult and I don't have these fancy tools. Then I just use what's in their fridge or their freezer. Persistent engorgement that doesn't seem to go away. You've done all the treatments, it's still not going away. Emptying the breast frequently, you're doing all the things. Now you've got plugged ducts. Whole nother story. So what's a plugged duct? A plugged duct usually only affects one side, and it comes on kind of gradually. But you can develop recurrent plugged ducts, which is not fun, and sometimes that leads to mastitis. But you can treat these plugged ducts at home on your own. So plugged ducts are essentially blocked milk ducts that need to be unclogged. And you'll usually notice a lump in the area, wedge-shaped area of engorgement. In the vicinity of that plug, the plug might shift as well. The duct might feel more painful or more tender before the feed and less after the feed once you've removed that milk. So nursing on the affected side might be a little bit more painful during the letdown, and that's to be expected. One way that's easy to get rid of these nasty little plugs is to dip the affected breast in a bowl of very, very warm water, as warm as you can take it, or you want to put it in there with a tablespoon or so of Epsom salts and throw that in there. Dip your breast in the water and let it touch. Let the tip of your nipple be touching that water. You want to do this about 2 to 3 times a day for about 10 minutes at a time. You can even massage when you do it to help release the plug. This is perfect. This is perfect. You may see the milk come out a little stringy, a little gelatin-like, a little clumpy, and that's normal. It might freak you out a little bit, but it's normal. It might even look like string cheese. I've seen that when I've actually removed clogs from people's breasts with this method. And just know that your milk supply or your pumping supply might be slightly reduced when you develop plugged ducts, and that's common and normal as well. You may notice this decrease just temporarily, a couple of days, and if it's past that, then definitely seek help. Also know that it's normal after plugged ducts or mastitis to still see some redness or bruising in the area that was affected for up to a week afterward. Number 3, mastitis. This is what happens when all of these things go untreated or unresolved. We develop mastitis. The persistent engorgement, the plugged ducts, the cracks in the nipples, those are things that allow bacteria to get inside through those cracks into the body, and it can create a little infection. And oftentimes we see this within the first 2 to 3 weeks postpartum. It can happen at any time during the lactation journey, but the first 2 to 3 weeks is most commonly when lactation consultants get calls about it. So mastitis comes on a little bit differently than a plugged duct. Mastitis is something that will come on not gradually, but it'll hit you strong. The local symptoms of mastitis are the same as a plugged duct. The pain and the swelling will be a little bit more intense. There might even be some red streaking extending from outward from the affected area. And the symptoms of mastitis include having a fever of 101.3 Fahrenheit or greater. You may have body aches, chills. So you might just feel like not yourself, and very flu-like, COVID-like symptoms, a systemic illness for sure. And if you think you have mastitis, then you definitely want to seek the help of a lactation professional or a doctor, OBGYN, or a midwife and ask them what you should do for your particular situation. If you're having a case of mastitis, you want to do plenty of rest. You want to do massage. You want to be draining the breast fully every time. And if you're experiencing more severe like symptoms, you may even need to contact your doctor to receive a prescription of antibiotics and just do a round of that in order to knock this infection out. But oftentimes just constant, heat, rest, massage, drain the breast, that's usually enough. If you're experiencing any of these things, heat, massage, rest, empty the breast. Heat, massage, rest, empty the breast. So an oversupply can seem like a great thing or a great problem to have, and it is not. Does your baby choke, gag, cough, gasp when they are drinking as though the milk is coming way too fast? Then you may have an oversupply or an overactive letdown. Is your baby pulling off the breast often? Are they making clicking sound? Do they spit out forcefully and often? Are they very gassy? Sometimes babies refuse to nurse when there's an overactive letdown or an oversupply because it's just too much too fast. So if this is the case for you, you want to avoid any extra breast stimulation or nipple stimulation. Avoid excess pumping. Avoid running the water over your breast for an extended period of time in the shower. Don't just stand in there, get in and get out. You can put it on your back, just don't directly let the water keep hitting your chest because that's causing stimulation. These are things that are all actively or passively stimulating your breast to create and tell your body to create more milk. And so if you're already dealing with too much milk and you don't want to create more, then you want to avoid doing those things. And if your baby is gaining weight well, then you can do something that we like to call block feeding. Block feeding might be the way to go if your baby is gaining weight well. Block feeding is just feeding on one side for an extended period of time and only that before you switch to the other side. And what you're trying to do is just completely drain one breast and before you move on to the other. We don't like to introduce milk production reduction techniques until after 4 to 6 weeks because we want to give that milk supply some time to establish and regulate. And if we interfere with that process too early on, we can negatively impact your milk production. Even if these measures don't completely solve your problem, you may find that your generous oversupply might actually scale back a little bit on its own if you give it some time. At least to some extent, it should subside on its own. And typically we see that around 12 weeks-ish. And this is when your body goes through these hormonal changes that happen to make your supply be regulated, to help your supply be more stable in line with what your baby actually needs. Number 5 is oral restrictions. Many babies have a piece of membrane under their tongue called a frenulum. It usually doesn't cause any problems, but a tongue tie, also known as ankyloglossia, is a condition. It occurs in some human infants and it restricts the motion of the tongue. So those are my top 5 reasons and remedies for breastfeeding pain and discomfort. If you like this video, please thumbs up. If you want to subscribe, hit the bell so you can get more videos from me. Be sure to check out all my social media platforms at Melanin Milk SD. Follow, share, comment, share with your clients, your friends, family, and relatives. Thank you for supporting my business. Thank you for watching. As always, take what you want, leave the rest. And until then, happy birthing.